will get their X chromosome from their mothers and the Y chromosome from the fathers. So we've all been taught that women, or females rather, with X-linked conditions are not themselves affected. However, in OTC and Fabry, there appears to be an intermediate phenotype where female carriers are, or at least may be, partially affected. And by this we mean that they do have the condition, but it affects them more mildly or at a later age than their male relatives with the same mutation. This arises because of the process of lionization, whereby one or other of the X chromosomes is randomly switched off in each cell of a female's body. And if it so happens that the affected X chromosome dominates, then females with the condition can be quite severely affected, but the reverse may also be true, and therefore if the unaffected X chromosome is primarily the one that's switched on, then they may be unaffected or only very mildly affected. The important point to take away, though, is that females with OTC and Fabry disease do or at least can have the condition. Hunters, that doesn't seem to be the case. I'm going to finish with a brief overview of the principles of treatment. So here we see again the slide showing the enzyme or cofactor defect affecting conversion of substrate B to product C. And one way in which we can treat IMDs is to remove or at least diminish substrate B by giving enzyme replacement therapy. That's particularly a strategy used in lysosomal storage disorders. In some cases, we can give very high doses of vitamin cofactors to overcome the metabolic block, either partially or fully. And in some disorders of vitamin or metal ion metabolism, we can give a very high dose of that vitamin to overcome the metabolic block. The other way we can diminish substrate B is to give a low substrate diet. And that's a strategy particularly used in the amino acid disorders. The best known example of that is in PKU, or phenylketonuria, where a very low protein diet means a very low intake of phenylalanine, which has really transformed the outlook for patients born with PKU, and much more about that later in the course. The third way is if energy is the problem, we can give an alternative energy source. So a good example of that is giving cornstarch in the hepatic glycogen storage disorders. Cornstarch is a source of glucose, which is released by the enzyme amylase. So it uses a different metabolic pathway from that, which is defective in the glycogen storage disorders. And finally, we can administer medication if removal of toxic metabolites, by removal of toxic metabolites, if that's the clinical problem. This slide just summarizes what I've said. So if substrate accumulation is the problem, Then two strategies to resolve that is by giving enzyme replacement therapy or high doses of vitamin cofactor, or limiting accumulation by dietary modification. If deficiency of end product is the problem, and this is seen where that end product is a source of energy, then replacement with an alternative source of energy is an effective strategy. And we talked about the example of cornstarch in some of the glycogen storage disorders. And finally, if accumulation of toxic metabolite is the problem, then we can remove that toxin using medication. And an example of that is in the urea cycle disorders, where we administer ammonia scavenging medication. But an interesting example, alternative example of that is in tyrosinemia, where upstream, the enzyme upstream of the toxic metabolites is inhibited using a medication called NTBC or nitisinone. And very often a combination of two or more treatment approaches is needed to optimally treat the patient. Some conditions put patients at risk of an acute metabolic emergency, and these tend to occur during periods of prolonged fasting, such as during an acute illness, particularly a diarrhea and vomiting illness, but also in the period of being nil by mouth during, well, before, during, and immediately after surgery. And the other time of extreme metabolic stress may be during pregnancy, and particularly in the peripartum. There are two consequences of prolonged fasting that put patients at risk, and both arise from muscle catabolism, which occurs during prolonged fasting. So the first consequence of this is that muscle catabolism generates a large pool of amino acids, which are required as a source of energy, but also as a source of amino acids for all the other functions of essential amino acids. And in urea cycle disorders, this excess protein causes an accumulation of excess ammonia, which can't be broken down in the urea cycle. Or it may be that this pool of amino acids results in accumulation of a specific toxic amino acid. And an example of this is the accumulation of leucine in maple syrup urine disease, which is toxic to brain, and like ammonia will cause encephalopathy. The other consequence of muscle catabolism is of prolonged fasting is depletion of energy. And in the fatty acid oxidation disorders, this can cause profound hypoglycemia and also muscle catabolism, leading to rhabdomyolysis. And the same can occur in hepatic glycogen storage disorders. So the principles of management is to prevent muscle catabolism, and this is done by providing an alternative fuel source. In some cases, we may need to administer medication to remove the toxic substance, and particularly notable examples are the urea cycle disorders, where we administer ammonia scavenging medication. In fact, many patients require ammonia scavenging medication all the time, but we may need to up the dose during times of metabolic crisis. Guidelines for the emergency management of the individual conditions can be found on the BIMDG website, and I would encourage you to go and look at these. They're freely available, open access, but there's quite a nice summary of the individual conditions on it within the guidelines. So emergency management is largely, if possible, managed at home, and this is where our team of expert dietitians are particularly involved. So a patient who is unwell at home will have a supply of glucose polymer in the form of SOS-25 or Maxigel, which is stirred into 200 ml of water and taken in sips. And dietitians will maintain regular contact with patients during this time, obviously, of course, involving the wider multidisciplinary team as well, and encourage patients to stay at home and take their SOS or Maxigel. But there often comes a time where they are unable to tolerate any form of oral food, fluids, or medication. And if this is the case, then we have to advise they come into hospital, and in hospital they'll be given 10% glucose intravenously with IV medication if applicable, particularly, as I said, in the urea cycle disorders. And they'll require close monitoring, both for routine observations, but also neurological observations for signs of encephalopathy. So that's all I wanted to say. I will just quickly summarize that. So we talked about how IMDs are genetic disorders affecting either directly or indirectly the activity of an enzyme involved in one of the metabolic pathways. They can cause illness by one or more of three ways, either by accumulation of substrate, depletion of a product required for energy generation, or by generation of toxic metabolites by an alternative pathway. Most are autosomal recessive, but a notable few are X-linked, and in particular we talked about Fabry disease and OTC, whereby females with the condition may be partially affected. They're treated by one or more strategies of removing substrate, giving an alternative energy source, or with medication to remove toxic byproducts. In some conditions, prolonged fasting during times of metabolic stress could precipitate an acute metabolic emergency, and it's important to manage patients very closely during these times. And we have guidance for that for the specific conditions, which are freely available on the BIMDG website. And finally, further reading. There's the little yellow book, Vademecum Metabolicum, which is a pocket-sized handbook in note form that gives you a very brief overview of all the major inherited metabolic disorders described so far. If you do spend time in an IMD centre, you will no doubt come across this book, but you can also download it onto your phones through Google Play or the App Store. The two major textbooks I would recommend are shown here. There's the BIMDG website for emergency management that we've talked about, and also the MetBioNet website, which has a number of both clinical and laboratory resources, including PDF presentations. So thank you for listening, and I hope you enjoy the rest of the course, and do please get in touch if you have any any questions. Thank you.